Thank you. Good afternoon, everybody. I'm going to try and speak up so you can hear me in the back of the room, and you can see they did the mic, but that doesn't really help with the acoustics. It's more for the audio visual. As we were just talking about, I am a family practitioner. I've been trained in hospital medicine. Briefly, you know what the hospitalists do? The ER calls us when somebody's too sick to go home. That's essentially what happens, and that's kind of how I introduce myself when I have to go to the ER and admit somebody to the patient. They have a terrific system here where we do inpatient medicine, and I hope that you don't have to experience that, but if you do, know that you're in good hands. What I primarily do is in my clinical practice, I like to focus on diabetes. When I started medical school, I thought I was going to be an endocrinologist, that's a gland specialist, but they end up doing mostly diabetes because it's so common. And decided that I wanted to do a little bit more than that. But I still have always had this fondness about managing diabetes, and it's because it's so manageable. And the fact that y'all are here today is testament that you want to get better control, or you know somebody you want to help with, and that's our goal. Okay? Any questions before we get started? Awesome. Yes, sir.
Yeah, is there any such thing? Harold.
I knew Harold would ask a question. That's a great question. We used to say that that was like being a little bit pregnant. Like there's no such thing. You are or you're not. But the truth is now that definition is creeping up on us, and it's a little more accurate than we used to think. We'll talk a little more about that in the lecture. That's a terrific question. So let's get started. What I want to do is I want all of y'all to be able to go out and give this talk to whomever.
Oh, yeah, right.
You're going to be an expert. That's the goal. Does anybody in here know anybody with diabetes? Heck yeah, right? Everybody does. That's how prevalent it is. It's incredible how it's grown. We'll talk about that in a second. Okay. So that's me. So the types. Type 1. Type 1 diabetes means you don't make insulin anymore. And throughout the presentation, I want you to think of insulin as the key that opens up those cells, because everything in the body runs on sugar, right? When I say sugar, when I say glucose, interchangeable. And that's what insulin does. It opens up those cells so the sugar can go in and fuel that motor. Whether it's a heart motor, brain motor, whatever cell in the body, that's what it needs. Type 1 diabetes, they don't make insulin. What's the treatment? Got to give them insulin. There's no getting around it, okay? Type 2 means you're still making insulin usually, but your body's resistant to it. You've got the key, which is the insulin, but it's harder to find the doors. It's harder to find those little keyholes. And that's what type 2 means. You're resistant to what your body's making. It doesn't use it efficiently. Well, if you can't open the door, the sugar can't go in, right? So keep that image in your head as we go forward. And then gestational diabetes is basically women who get diabetes while they're pregnant. And that has a lot to do with hormones and insulin resistance and things like that. And the reason that's important is because they're at increased risk of developing diabetes later in life. The danger with gestational diabetes usually has to do with the size of the baby, because all that sugar crosses the placenta and the baby can get really big. So whenever y'all hear this on the news, 15-pound baby, 12-pound baby. The biggest one I ever tried to deliver, because it didn't work, was 11 pounds. And of course we had to do a C-section. That's why it's dangerous, because then they have to go to surgery. So whenever we find out that people either have diabetes when they get pregnant or they develop it during pregnancy, we pay close attention and make sure that we try to control the blood sugars, as in always, but especially under those circumstances. And we'll talk more about your question, I promise. So type 1, it's essentially what I just said. You're not making insulin anymore. If you can imagine, anybody here a football fan? Minnesota Vikings, imagine their helmet. The horn on the side of the helmet of the Minnesota Vikings, that's what your pancreas looks like, and it's right about here. That's what makes insulin. It's a gland that makes insulin. It makes other things too, digestive enzymes, but in this case it's not working anymore. Why? What we think happens, and we're getting closer to really understanding this, there are people in the world whose immune system has bad vision, needs glasses but doesn't have them. And so the antibodies that develop to try to kill a virus, usually chickenpox we seem to think, gets bad vision and looks at the pancreas and says, that's a chickenpox virus I killed. Come on guys, come on ladies, let's go jump on those cells. And that's what happens. The body's immune system attacks the cells that make insulin. The pancreas keeps on producing digestive enzymes, no problem, but it doesn't make insulin anymore. That's type 1. Usually happens in kids, but it can happen anytime. And so these are other words that we use. Juvenile, we don't use that so much except when we're talking about the foundation that helps research. But that's essentially in a nutshell what that is. Okay, so type 1, again, we can't make insulin anymore. I mentioned the immune mediated, and there are times when we just don't know. If you ask the mom or dad, has Susan been sick? Well, yeah, she had this rash a couple weeks ago. We thought it was chickenpox, didn't know. We're not seeing that as much now because we have the new vaccine, right? The chickenpox vaccine that we give to kids and even to adults to try to prevent shingles. And so our hope is that by doing that, maybe we can prevent some of this. Just don't know yet. It's too early. Questions about type 1?
What is idiom?
Idiopathic is one of our fancy words, and I'll try not to use many of them. It's half of medical school learning the daggum words. Idiopathic is a fancy word that means we don't know. So if your doctor tries to impress you and says, oh ma'am, it's idiopathic, you'll know he just doesn't know, or she. Thank you for pointing that out. All right, so this usually comes on quickly. We usually diagnose this in the ER. The person comes in and they're sweating and they've been drinking a lot and they've been peeing a lot. We'll talk in a minute about why that happens. And they've been losing weight, and we check the blood sugar and it's sky high, 1,000 or more. And we usually pick these up real quick. There's not as many of these, but I want you to know about this, okay? About 1 million in the United States at last count. Why do you think they're thin usually? Any ideas? It's because the body is tricked. It says there's no sugar here. Well, there's plenty of sugar. It's all on the bloodstream though. Remember, it can't get in the cell. It doesn't have the key to unlock the door. So the body starts burning fat to try to fuel the system. And they lose weight. It's a terrible way to lose weight. All right, so here are the symptoms. We talked about thirsty. Why are you thirsty? Because A, your body is trying to get rid of all that sugar that's in the bloodstream, so you're going to the bathroom a lot. Peeing, not a little bit, a lot. Often. The kidneys are saying, what is this? And they're trying to get rid of it. You're hungry because your body's burning fat, right? And it thinks there's no sugar. Where is my fuel? And the weight loss I mentioned. All right. So I misquoted. As many as 3 million now. JDRF, if any of you have ever worked with Juvenile Diabetes Research Foundation, great group. 93 cents of every dollar goes directly to research. They are awesome. That's one of the best charities I've ever been involved with. So if you ever get a chance to participate, and they do a lot of stuff for type 2. I don't mean to say it's only type 1. Very good group.
Like I sent to St. Jude.
Also a good group.
15 different things. How can you do it without like going through that major?
There's a local chapter in Greenville. I'll give you the phone number before we adjourn, and I can't remember off the top of my head, or I'll give it to you now. And you can just call them because they have walkathons. They have all kinds of neat outreach things that they do for anybody with diabetes, not just type 1. But they do some great things with kids. When they're first diagnosed, you can imagine how terrifying that is for the kids, the family, everybody. And it's really amazing. And I'll talk more about insulin pumps later, but we put insulin pumps on kids. Sometimes we get them for free. It's a good group. So I'll give you the phone number. Type 2, that's the other kind. Remember? Do you still make insulin? You sure do. But your body's not using it efficiently. In fact, your pancreas starts working overtime. Got to make more, got to make more. And there are times when it just says, I'm done. I've been making all this extra insulin, you're not responding, and it shuts off the factory, and then they need insulin too. Sometimes we'll add insulin just to keep that from happening. I often do that, and people do really well when we add insulin. So if you've been put on insulin and you're type 2, don't think that means you're doing anything terrible. It's just an individualized, customized therapy that often works really well. Okay, so it's really, really common, and definitely the most common type. I'm going to talk about the numbers here in a second. 25 million that we know about now. Why do we say it like that? Because we don't know everybody that's got diabetes. We haven't diagnosed it yet. We don't find them in the ER. They may have it for 10 years before we notice. They come in, the eyesight's changed. I just got these glasses, doc, my eyesight's changed again. Or my feet are kind of numb and tingling. What's going on? Things like that. And sometimes that's when we pick it up, when the horse is a little bit out of the barn, not completely. So that's why I say diagnosed, undiagnosed, pre-diabetes to the gentleman's question, and I'll tell you how to figure that out in a second. And there's the new cases. And I recently heard the impact on the healthcare system, and y'all, it's through the roof. The cost of managing diabetes and its complications, billions and billions of dollars. It's monstrous. And so we want to get better at that because we don't want to spend y'all's money, nor should we. But the most important thing is we want you to be healthier. So one will follow the other if we do it right. This is not designed to be a doom and gloom slide, but it is sobering. And this is straight from the American Diabetes Association. That's where these numbers are from. And it lists on the death certificate because it could be kidney failure secondary to diabetes or what have you. Anyway, the point is, if we control the blood sugars by understanding the disease and getting the right medications, we can often prevent the complications. That's the whole goal. All right. Questions so far? I appreciate y'all speaking up if you have one. Just let it fly. I'm not very formal. Hopefully you've noticed. All right, what are the risk factors? Obesity. Why? Remember I told you all of our cells work on sugar, glucose. Well, what if those cells and the doors that the insulin fits into get bigger? That same key that fits those doors, the insulin, it's harder for it to find the doorknobs. That's why often, and you've probably seen this, when people lose weight or get their weight under control, often their blood sugars will get much better, even to the point where they don't have to take medication anymore. Happens all the time. It's very common, and that's why obesity is a risk factor, because it can make you more insulin resistant, harder to find the doors. Family history, of course, you know, genetics kind of comes into play on just about everything. Certain ethnic groups, there's a group in Arizona of Native Americans, the Pima Indians, and they get everything. I mean, if you think of a disease, look it up and you'll see somewhere in the description, common among Pima Indians. And you know, and part of that's because it's a closed community and they intermarry and things like that. It happens in some other cultures too. And that's basically what that's talking about. And female gender, they think that has to do with women that sometimes have polycystic ovarian syndrome, if you've ever heard of that. When I was in mama, all of us guys, our parts were up here, just like ovaries, and they slid down, of course, when you add testosterone. Well, if you can imagine ovaries being here and getting cysts on them, that makes you more insulin resistant. So that's why it says female gender, okay? And then there are conditions that have insulin resistance, and that could be medication, it could be any number of things. All right, so how do we diagnose this? Did y'all know this before it popped up? Check your blood sugar first thing in the morning. If it's greater than 126, that's not enough. We got to get another one greater than 126. That's diagnostic. The thing that I really like, I'm going to point this out, A1C. Anybody know what an A1C is? What the heck does that mean, right? That's what I used to think. Every time they bring it up in med school, I fortunately knew about it because I'd done some diabetes stuff before. Why do you call it A1C? It's an average blood sugar for 3 to 4 months. That's what that means. So why not change the name? Wouldn't that be easier to understand? Average blood sugar. You don't even have to say the time frame. That's what an A1C is. So when your doctor's talking about that, who named it that? I don't know. That's what they're talking about. A 7 on an A1C is an average blood sugar of 150, 150. The reason I'm pointing all that out is because that's a great test for us to do, because we can tell now not just what your blood sugar is doing at this moment, but what it's been doing for 3 to 4 months. Why 3 to 4 months? You remember I told you sugar travels through the body? The way it travels is on a red blood cell. Okay, it's got its own little cell that it travels on, and that's how long a red blood cell lives, 3 to 4 months. If the A1C is greater than 6.5, in this case that correlates to just about 126, then that's diagnostic. Back to your question, sir. Pre-diabetes, when I get an A1C on somebody in my office, if it's in this range, I'm watching them. I'm watching them real close. And I might not say borderline diabetic or borderline pregnant or borderline anything else. But I will definitely tell them that it appears you're insulin resistant to a degree. We need to keep an eye on this. And we'll keep watching it, and I usually repeat that once a year. That's the recommendation. So now there is such a thing. All right, so here are the symptoms. We talked a little bit about this in the various places. Why do you think we have eye changes? You remember I told you how sugar travels through the body on that little red blood cell? Red blood cells can go in and out of the globe that is the eye with or without insulin. It's pretty easy to fly in, fly back out, and the globe of the eye literally expands and the focus changes. And that's why sometimes even eye doctors will pick up diabetes way before we ever knew that they had it. And then some of these other words, you remember I told you we got these fancy words for everything. Polydipsia, that's a lot of drinking. Polyphagia, that's real hungry. Why would you be tired? You got plenty of sugar. Your blood sugar's 250 for heaven's sakes. Why are we tired? Because it's still in the bloodstream. It's not where it's supposed to be. It's not fueling all the stuff it's supposed to be fueling. So you can feel real tired. That smell of acetone and ketones that sometimes come out in the urine, that's exhaust. That's the exhaust that's given off by the car, being the body, when it's burning fat. When your body is tricked into thinking that it's in the Mojave Desert and we got no sugar, what the heck are we going to do? Let's burn some fat. Ketones is what it gives off when it burns fat.
Is that common? Well,
It's common in type 1, more common in type 1. But you can see that, smell that under certain circumstances. Yes, ma'am.
you smell it yourself, of yourself.
You'd smell it, but you might not recognize it because you're busy feeling all these other things. The lethargy and the stupor, and I can barely stand up.
But a doctor would know.
It smells like juicy fruit gum.
Huh.
That's what it smells like. I'm just going to touch on this for a second. Respiratory. When your body burns fat, again, why does it burn fat? It's tricked into thinking you're starving. It gives off these ketones. Well, they're acid. They're acidotic. And so they lower the pH in your body. So your body says, what the heck? Let's breathe faster. And when you breathe faster, you give off more carbon dioxide, and that's also acidic. Not in a dangerous level, so it's your body compensating, trying to raise this pH back up. So if you've ever heard any of these descriptions, I just want you to at least have heard it and had somebody say, well, that's what that's all about. Questions about this? All right. So how do we monitor? Y'all all know, you blood sugar check, right? Who monitors more than 3 times a day? Anybody? Sometimes we'll have people do that when we first make the diagnosis because we want to know when the blood sugars are elevated. That's a blood sugar meter there in the middle. The reason I put this over here is because this is something that's on the horizon. It's called a glucose watch. It's designed to pick up the sugar, glucose, in your interstitial fluid. Have y'all ever seen one of these meters where you can check on your arm? You've seen them advertised on television, right? It's the same principle. You're not checking blood, but you're still getting an idea of what your blood sugar's like through that fluid, that interstitial fluid. That's what these monitors on the watch check. And it actually works. The downside is at this point, the little sensors that go on the back you have to replace every 3, 4, 5 days, and they're about $200 a piece. So, but you know that's going to lower. It'll probably be a viable product in the future.
What's that fluid that you said?
Interstitial, between the cells. It's just, you know, everything, all the fluids in our body is not specifically blood. And even if I had some blood here in my hand or in a pint of, you know, a container, it's not all red blood cells. Some of it's fluid. And that's essentially what we're talking about, because that's also how this stuff travels. So how do we treat it? Why would it be diet? Well, because we're trying to minimize the sugar that we're putting in our body so that our pancreas can keep up. Exercise, why is that important? Well, because it can help us lose weight, number one, of course, and those cells that are hard to find, the insulin sites, shrink back down. The other thing is there are muscles in your body, big muscles, thigh, hips, shoulder muscles, that will pull that sugar in with or without insulin. And in some countries they actually use that as a treatment. I was in St. Martin once. We developed a diabetes camp, and that's all we had. We didn't have the medicine. We had them do jumping jacks if their blood sugars were really high. And it sounds crazy, but we used the tools that we had. So if we'll exercise, our insulin resistance improves. All right, how do we treat it? Remember I told you you're insulin sensitive, so there are medicines that make you more insulin. I said that wrong. There are medicines that make you more sensitive to the insulin that you're making. Metformin comes to mind, if anybody's heard of that. That's one of the most common ones. Liver blockers. Well, guess what? All the sugar in your body doesn't come from what we eat. Your liver makes sugar. It's supposed to. So if you skip a meal, you can keep on functioning. It's not fun. And so there are sometimes when we want to block that, things that slow down the digestion. Why is that important? Because it gives the pancreas time to catch up. And then sometimes we'll even make the pancreas make some more insulin. Hey, wake up! Give me some more insulin.
What slows down the digestion?
What slows down your digestion? The easiest answer is foods with a lot of fiber in them. But anything with protein, and not that I'm recommending a high-fat meal, but fat takes forever to digest. The reason I say it that way is because instead of eating a piece of white bread, I might eat a piece of wheat bread and have a chicken breast with it. So I've slowed it down in 2 ways, because protein that's in the chicken breast will take a while to digest. And so that often helps very much with, not only with diabetes, but it keeps you from being hungry, you know, half an hour later. Things that digest really quickly make the blood sugar go up. The pancreas says, oh, I get it. Here's your insulin. And sometimes it overdoes it. You feel hungry again. It opened those doors, the sugar went in, and now you almost feel like you've got low blood sugar. I just put this in here because I want to kind of point out briefly insulin when it was first developed. You remember I told you the pancreas makes it, and there was a time when the treatment for diabetes was starvation. How horrible, right? This is a fascinating book on the development of insulin. The Eli Lilly company did it. But this kid on the bottom is before and after insulin. So think about this, okay? Insulin doesn't exist except in the body, so somebody came up with an idea of taking pancreases from pigs and cows and grinding them up. And that's what they did. And it was in Canada. It was just across the border. So people that had children like this sold all their worldly goods, picked up and beat a trail to Canada. I mean, wouldn't you do anything for your child? Of course you would. And then they get there and there's not enough to go around. It's a heartbreaking but then heartwarming story because they increase production and things develop from there. Now the insulin that we use is all synthetic. It's not from animals at all. But that's the way it started, and it's really kind of cool. Needles is the way we inject insulin. If you've ever seen anybody do it or if you've ever done it yourself, you know that. We use the tiny, tiny needles now. But insulin's a hormone, so you can't eat it. You'll digest it, just like the steak or the chicken I was talking about before. Insulin pumps, I'll show you one of those in a minute. It's designed to be an artificial pancreas. Looks like a pager on your hip. And it has a little site where the insulin goes in. I'll show you a picture. And then implantables. That's just a way of putting the same thing inside the body and refilling it whenever the insulin runs low. There's the picture I was talking about. This up top, that's an insulin pump, and this is what we call the site. It has a 5mm Teflon cannula. It's an open tube that sits in the skin. You can't even feel it. Honestly, I mean, I've done it myself many times. It goes in with a needle and you throw the needle away, and it stays there just like what we use for IVs here, except there are not many nerve endings here, so you don't really feel it. It's got a little special device that puts it in there. And then it hooks up to the pump, which is what this is. That's where the insulin is. And it gives you this nice steady stream of insulin just like the pancreas would, and then when you eat, it comes with a remote, or you can just push the buttons and give yourself extra insulin, or if your high blood sugar pops up on the meter, that's what you do. Needles, you've probably all seen these. That's the implantable. It delivers insulin right into the portal vein, which is the vein that goes to the liver. And then this on the bottom is the marriage between an insulin pump and a blood sugar sensor. This blood sugar sensor checks your blood sugar every 12 seconds and sends a signal every 5 minutes to the pump and says, blood sugar's kind of high, can you give me a little more? It's very, very close to an artificial pancreas. And these things all exist. I have a couple of patients on this one. I have a bunch of patients on this.
Any the age of the patient, that'd be more inclined to take that?
The age of the patient for an insulin pump or a meter, an external meter or continuous, no, it doesn't matter. If you need insulin, you can be on one of those pumps. I have 5, maybe 6 patients that are type 2 that were supplementing their medication with extra insulin, and they're taking a ton of insulin. They're resistant. So we put them on a pump, they're doing beautifully. You see them a lot with kids. The youngest kid I've ever done a pump on was about 6 months of age. And then, of course, that was a new diagnosis. But worked beautifully, and this kid was growing like crazy, so of course it needed extra insulin, and just did really well. And we just put a little belt on him, and the site in this case went right on the top of his hip. You change that every 3 days. You disconnect. We say disconnect for the 3 S's: swimming, shower, and sex. And you can just disconnect from the pump. You got a little Band-Aid there. That's it for me. Questions?